Alrighty. Hey everyone, I'm going to be going over peptic ulcer disease. Um, this is just one video only. I'm going to be doing GERD and GI bleeding, like other topics later. But right now it's just for peptic ulcer disease. Okay, so peptic ulcer disease, it's in the name, so it's an erosion of the mucosal lining in the stomach, esophagus, and duodenum, right? And if perforation does occur, peritonitis, which is the inflammation in the, is it peritoneal? The peritoneal cavity, which is the sac that goes, that's like around our abdominal area and like our organs, like the stomach, the liver, all that stuff. So if perforation, right, which is where a puncture or hole were to go through our stomach and, you know, acid and stuff was to get there, all bacteria, then peritonitis can form, and even worse, hypovolemic shock and sepsis. Okay, it's not to get off topic, but some risk factors of peptic ulcer disease could be the H. pylori infection, which is pretty much a bacterial infection. Yeah, a bacterial infection that's in the pylorus area of the stomach, so which is more near the like bottom area of the stomach leading into the small intestine or the duodenum. So that can really happen. So some risk factors would be H. pylori infection, NSAIDs and corticosteroid use. Why? Because it increases the gastric acid content, which is hydrogen chloride and pepsin. So when we take NSAIDs and other sorts, it can probably cause GI burning or upset because of the increased acidity due to the NSAIDs. And then another risk factor can be severe stress. Obviously, you know, anytime we're stressed out, anything can happen with our body. So we can even have stomach ulcers due to stress, and it can cause bleeding. And I just put nursing student because common in nursing students. All right, so for tumors, tumors of the pancreas that secretes gastric contents. So for this, we know with tumors, it could possibly add a pressure to somewhere. So since it secretes a lot of gastric content, the pressure plus acidity can cause and form an ulcer, where ulcers are pretty much where they like erode through the granulation tissue of the stomach, or just, you know, the tissue of the stomach, and hits a major blood vessel. So that's where we see the bleeding, and that's where we see like the holes and like the dips in the muscle or the tissue. And then people that have type O blood, I didn't really look too much into it, but when I did search it up, it said that people with type O blood, it tends to bind more with the mucosal lining, so it makes it easier or something for infections and ulcers to form. So type O blood. And then people that have pernicious edema, which I'll tell you guys about later, but you want to make sure they get vitamin B12. People that have pernicious edema, and then people that drink a lot of alcohol. So alcohol, you know, it's like it's carbonated, so it can burn, so it causes GI upset like gastritis and stuff. So excessive alcohol, chronic pulmonary kidney disease. I really don't know much about this one. I'm trying to think of how, but I really just don't know how it deals with the stomach. So just know it. And then Zollinger-Ellison syndrome. So this is like the triple whammy. Like this is like you got all of it. So you have peptic ulcers, hypersecretion of acid, right? So their stomach acid is very, very like acidic, and tumors, because, you know, they could probably have tumors in the pancreas area or around the stomach, causing pressure and stuff. So yeah. So some expected findings of peptic ulcer disease would be dyspepsia, which is like the nausea, the vomiting, and like the bloating and like the heartburn that people get usually with peptic ulcer diseases. Even with GERD and gastritis, they usually tend to show presentations of dyspepsia. And then there's also a more specific term with dyspepsia, because in certain books it says that it's the heartburn or the burning sensation. but it's actually called pyrosis, which is the burning slash angina, which is chest pain that can be mistaken for MI, that most people with GERD and like gastritis feel in the epigastric area, or even the lower gastric area, you know, that they really feel that burning sensation because of the acid and the bleeding. And then some things, if a patient were to report to you, you want to make sure that it matches up with, you know, that they have dull pain in the mid-epigastric area slash burning. So the mid-epigastric area is literally right here. And I want to say, if my anatomy is right, literally what's right here is the beginning of the LES sphincter, or the end of this esophagus leading into the stomach. I could be wrong, but images show like that on pictures. So yeah. And then there's different types of ulcers, right? So there's gastric, duodenal, and then there's curling and Cushing's. But the main big ones, and they're stress, but the main big ones that we want to know for sure is gastric and duodenal. And you want to know the difference. So gastric ulcers, right? They can present with hematoemesis. I hope I said that right. Which is hemat, which is blood. Emesis is throwing up. So they can, if they present with like bloody vomit that looks like coffee grounds, it's most likely that they have a gastric ulcer, right? It's less common in people, and usually the pain happens within 30 minutes to an hour after eating food. And the pain actually gets worse when people eat food that has gastric ulcers. And the way I think about it is the gastric, like upper area where everything is just being broken down at, right? So if you got food and you're working around with cuts and burns and stuff, it's gonna burn, it's gonna hurt, and all those type of things. So you wanna make sure, you know, you're looking out for that. So they can have pain after eating, they can be malnourished because of them having constant pain, they're not gonna wanna eat so much. So you wanna make sure they get enough nutrients that they need. And then they can have a burning and feeling like nauseous and gaseous feeling, like they always feel like they have to like always burp, and they got like so much like gas up in there. And then duodenal ulcers are the most common in people that have ulcers. And usually this pain is relieved with food. So when I think of this, I think of like you got a burn at the duodenal area, which is near like the end leading into the small intestine of the stomach. You know, you got a burn or an ulcer, right? And then once you put the food and stuff there, it kind of just put pressure and it coats it to where, you know, the pain isn't really there. So this happens to 1.5 to 3 hours after eating meals. But the only thing is you can they can have awakening pain at night, and they are pretty well nourished because since, you know, if the pain is relieved by eating food, they're gonna want to eat more food so the pain don't be there. You know what I'm saying? So yeah. And then this one, it's increased with people that have type O blood, and then they can have melena, whatever it's called. And this is where it's like dark, tarry stool. So it can look black, it can look super, super dark, it can look like sludgy, like all of those type of things. And then we have curling ulcers, which is like burns, and then Cushing is from like head and brain. So Cushing, I always think of head too, because they have like that moon face. So yeah. And then stress ulcers are like psychological causes. So like when nursing students are very stressed out, they can develop stress ulcers in the GI tract, and the most common like manifestation that you see would be the GI bleeding, which is usually in a stool or if they vomit it up. And then for an acute ulcer, usually acute ulcers happen from like after trauma incidents or surgery. So yeah. And then let's see what else. Let's go over to medications. So for medications, so in the study guide, it says they receive sulforaphane and H2 receptors, but they also receive more. They receive Tums, they receive PPIs, H2 receptors, sulforaphane. Let's see what else would they receive. What else? They receive antibiotics in case they have a perforation and they have sepsis. So you want to, or even H. pylori. So you want to make sure they can be on antibiotics too. But yeah, so pretty much with the H2 receptors, like if an acute ulcer is presented, you can push or you can give famotidine through an IV, And then the other ones, they can take with or without food, and you want to notify the provider if bleeding occurs. Like, it's simple. And then PPI, which is the Zols, also the most common one that people get when they have like nausea or gastritis would be Protonix, which is also known as omeprazole, I think. And pretty much this one, it can increase risk for pneumonia, fractures, so I would assume osteoporosis, and C. diff. I don't know how with C. diff, but I just know. And then sucralfate is a mucosal protectant. So like, there's this thing called cytoprotective, so it's a mucosal protectant, right? So bismuth, subsalicylate, whatever it's called. I just think of Pepto-Bismol. It coats the inside of the stomach, right? And it helps prevent H. pylori from binding to the wall. But pretty much this here, let's see what it says. Yeah, it just coats and protects the stomach from the gastric acid, right, from increasing and causing more ulcers and burns. And the one thing you want to do for sure if you're taking sulfate is you want to avoid aspirin because you can be at risk for the salicylate toxicity, and from that it's not good. And then if a client ever comes to you and says, oh, I have like black poop or black stools, you want to let them know that it is harmless and it is temporary. Okay, what's next? So then we have some complications on this side over here. So some complications, most common would be the hemorrhaging, which is bleeding, right? So with this, it goes, like I said, the ulcer goes through the tissue and then hits a major blood vessel where we see the bleeding, right? And it can present as bright red vomit or stool and can cause decreased hematocrit because you're bleeding out, so you have a really low hematocrit level. And then perforation, which is similar to the same thing, but it's more of like a puncture, and now the gastric acid is coming out instead of coming out with the blood and bacteria. So with perforation, it's a medical emergency, right? It can lead to peritonitis. Usually people that have peptic ulcer disease or have a perforation, they have a very hard, like rigid board-like abdomen upon palpation, right? They can have hyperactive bowel sounds in the beginning, but then it does become absent because I like to think of it as like, all that fluid's there, it's perforated, there's no more motility. It's like you need to hurry up and try to get surgery. So it can cause hypovolemic shock because they're losing blood out of the area, and it can also cause sepsis because of the bacteria within our like body sterile field. Let's see. It can also, when this happens, people can have hypotension, and I feel like this is very important because we probably always get asked on this, right? So they can have hypotension, tachycardia because they need to compensate for the hypovolemic shock, right? They can have nausea and vomiting, like always, rigid board abdomen, and they have shallow rapid breathing, right? Because they're compensating for the shock. And then they can have, again, hyperactive to absent bowel sounds, right? And after surgery and someone has sepsis, usually the treatment would be a broad spectrum antibiotic, because sepsis is very bacterial within the sterile field, so it's very dangerous. And then let's see what else here. We have pernicious anemia, which is where a deficiency of vitamin B12 is malabsorbed, or there's a malabsorption in the stomach, so it doesn't absorb it. So that person would need to be on a lifelong vitamin B12, either injection or whatever, how it goes. And then we have dumping syndrome, right? So dumping syndrome is pretty much when anything you eat, it comes literally right out. Like, it doesn't even digest fully, it just comes right back out. So it's rapid gastric emptying or very high carb intake. A late sign can be hypoglycemia. Yeah. And if one thing you do want to tell them is to lie down after eating because it slows down the ingestion. And then you want to tell them to avoid milk and sugars because milk can be it can make us use the bathroom. Same thing with sugar. So you want to tell them to avoid foods like that really make us go to the bathroom. And then no liquids 1 hour before meals. So yeah. And then let's see. Treatment for hypovolemic shock, right? So it can be fluid replacement, surgery, blood transfusion, right? And you always want to check the hematocrit levels and electrolytes. So they might receive lactated ringers with it. And then with treatment of this to stop the spillage of the perforations and the hemorrhage, right? You want to insert an NG tube and decrease the gastric acids from it to keep on spilling outward. So you want to decompress to have a gastric emptying from the NG tube, and then you want to also provide them IV solutions like lactated ringers and albumin, which is a protein in the blood. So, yeah. And then pyloric gastric obstruction. So it's located in the atrium and the prepyloric and the pyloric area, which is near like the end of the stomach leading into the duodenum, right? So then again, if someone has an obstruction, it's similar to a perforation or like a hemorrhage. So like there's like a puncture or like there's like a breakdown, right? So you want to decompress the stomach through an NG tube. And then if the pain worsens usually the pain worsens towards the end of the day because the stomach fills and dilates, right? So I like to think of it as a balloon. When something is so filled up, it'll pop. So you want to make sure it can be relieved by vomiting and belching because it's being unstretched. So you really just want to decompress with that one. And then some nursing actions for pretty much with the complications. You can do a nasogastric or NG tube saline lavage, which is cleaning out or washing out the area with saline and whatever. And then you want to prepare the client for an endoscopy or surgical intervention. So if a question ever asked you, like, what should the nurse anticipate or prepare for, and it would be endoscopy or endoscopic, whatever it's called, intervention, and you want to have 2 large bore IVs for access for blood and for fluid replacement. And that is literally peptic ulcer disease. Like, that's it. And for antacids, I forgot laboratory tests. So for laboratory tests, they can do H. pylori testing to test if they have a H. pylori infection, and a urea breath test, right, where they test it for H. pylori too, whatever. And some things like the diagnostic, it'll say EGD or esophageal gastroduodenoscopy, whatever it's called. So yeah, this is peptic ulcer disease. I hope this is very helpful. Take screenshots, zoom in as needed, and thank you guys for listening.